Oh, yes, if you don't mind. Hopefully we'll get through these pretty quickly, but I will be happy to answer them afterward. All right, so as I mentioned before, really the sort of take-home message here is that continuous movement is key. So if anything stops, stagnation equals death. You don't want that. And part of that is because although diffusion is great, diffusion by itself is slow. So the larger the diffusion distance, the longer diffusion takes, so the slower the diffusion rate. So if I were to, for example, wait for a particle to diffuse from the area of my heart to, say, down to my foot, that's a huge diffusion distance. And if I didn't have a pump to push it there, the rate that that would take for diffusion, all other things being equal, is about 27 years, which I don't have time for. So constant motion is important. Other things to note: insoluble lipids and tissue proteins that can't cross the capillary walls sometimes enter lymph. So the lipids component we'll discuss again when we get to the digestive system, because that's actually how your lipids are absorbed. So all the other macromolecules of life, so your carbohydrates, amino acids, etc., those enter your blood capillaries inside of your intestines. The lipids actually enter a specialized lymphatic capillary. So your lymphatic system has a lot to do with your fat metabolism, it turns out. Microbes and microbe toxins are also carried to lymphoid tissue. So this is one of the ways that lymph helps to clean your blood, and that's that it carries toxins away from your tissues and into your lymphatic system so that they can be dealt with. Okay, so what might affect filtration? Remember, filtration is the word we use for the driving force that is related to capillary hydrostatic pressure. Hemorrhage is one of those. So if you have a low blood volume, that means that the hydrostatic pressure at the arterial end of your capillary is going to drop below 35 millimeters of mercury, which creates less filtration. So if there's less filtration, you get more reabsorption, and that increases blood volume. So there's some action at the capillary bed that naturally opposes hemorrhages due to this, and this is called recall of fluids. Dehydration also does this. So lower blood volume is just due to you're losing water faster than you're gaining it. This increases blood colloid osmotic pressure, which causes more reabsorption, because if your BCOP is already higher than your interstitial hydrostatic pressure, and now it's even more so, we're going to be taking more fluid back from the interstitial spaces than usual. So at the capillary bed, there's natural mechanisms that oppose fluid loss. So recall of fluids means movement of fluid from the interstitial tissues back into the blood. Unfortunately, this can have negative consequences in some cases. So for example, profound dehydration often causes headaches and other discomforts, and one of the reasons for that is that recall of fluids function. So basically it turns your peripheral tissues into a raisin in the interest of raising your blood volume. Edema, spelled E-D-E-M-A, this is what happens if either of two things occurs. If capillary hydrostatic pressure rises, so for example, due to high blood pressure, or blood colloid osmotic pressure drops. So if your BCOP is low, that means that there's less of a driving force to take fluid back from the venous end of your capillary, which means that it stays in your tissues and creates edema. Or if CHP rises, that's another aspect of it. A lot of times these two things co-occur as well. So I know that many of you are here because you want to be nurses, not all of you, of course, but many. And one part of good nursing is especially depending on where you work, obviously. But edema is a pretty common finding in a variety of pathologies, and especially in America, where we have a lot of problems with heart disease and blood pressure. Those are sort of public health issues for us. Edema is a pretty common medical finding, so it's something that you're likely to encounter in the course of professional life. So either or both increase blood hydrostatic pressure or decrease plasma protein. Another consequence can be increased permeability of capillaries. So localized edema is actually pretty normal, and that's the swelling and puffiness that you see around, for example, an infected zit or a cut, right? So localized permeability increases are due to the action of basophils and mast cells, which, remember, release histamine and heparin, which increase capillary permeability and thin the blood. Blockage of lymphatics is another cause of edema, and it says parentheses here, later chapter, but remember, the lymphatic portion of the immune system chapter is one of the ones that I ended up cutting out for material this term because of the short time. So real quick about that, that 15% of the fluid that goes back into the lymph, if you block the lymphatic vessel with something, that fluid has nowhere to go. So it tends to build up in the periphery, and we call that elephantiasis. So elephantiasis is still a problem in undeveloped countries. It's typically due to small worms that block the lymphatic system. Gross, I know. But it can also be due to buildup of silicates in the lymphatic system. So those are little tiny microscopic shards of glass that come from volcanic soil. Okay, so cardiovascular regulation. If you look here, we have these two little nested components. So we have autoregulation, which is just self-regulation. So systems regulating themselves without higher up input. But that plugs into central regulation. So regulation involving the nervous system and the endocrine system. And the reason we have such a robust system of regulation is so that if one small part of the system changes, there's a bunch of other ways to fix it. And that's because tissue perfusion is key to remaining alive. Any interruption in tissue perfusion is going to create problems, so having multiple ways to oppose a loss of tissue perfusion is really important for health and homeostasis. So cardiac output and resistance are regulated. So you regulate your resistance, for example, by changing the diameter of blood vessels. You can also regulate resistance by changing blood volume, just to give you two examples. So let's zoom in a little bit and look at some aspects of this without doing a deep dive. So for example, let's look at some disturbance of homeostasis. So physical stress, chemical changes, or increased tissue activity. These can cause a drop in local blood pressure and flow. But if you release local vasodilators, like histamine, you get a local decrease in resistance and an increase in flow, which hopefully in the small term restores homeostasis. So that's an example. If this is insufficient, then you get into things like the renin-angiotensin system, which we have discussed, and the aldosterone system, which is linked to that, and others. So let's look at autoregulation first. We've got vasodilators and vasoconstrictors, and these are just going to either allow more blood to enter the capillary bed or prevent it. So we've got local effects on arterioles and precapillary sphincters. These are both physical and chemical. So for example, stretching of the arterioles changes the way they're autoregulated, as well as vasodilators and vasoconstrictors that are chemical. So Vasodilators. Nitric oxide is a big one. So remember, this is what is called a gasotransmitter. It's a dissolved gas that functions as a neurotransmitter. It's a very potent vasodilator. So we talked about it this term on terms of being related to achievement of penile and clitoral erection. So it's the primary mover of that, among other things. Potassium and hydrogen ions, lactic acid, increased temperature, low O2. So if you experience a local drop in oxygen, these automatically open to allow more oxygenated blood through, and high carbon dioxide. Vasoconstrictors are the opposite. So these are certain eicosanoids, not all of them, angiotensin and endothelins. These cause the capillaries to constrict, and their release is mediated by a fairly complex set of feedback loops and mechanisms, and we just don't have time to get into them here, so we're not going to. I do want to address the vasodilators thing again, because a lot of people are here for nursing. Hypovolemic shock, which is something we'll discuss shortly, means shock induced by low blood volume. Now, typically hypovolemic shock is caused by loss of blood. So you're supposed to have blood in your tubes. The blood's no longer in the tubes. Not always, though. So sepsis, which is a way of talking about the presence of bacteria and bacterial toxins in the bloodstream. Body sepsis can cause hypovolemic shock even without causing hemorrhaging. One of the ways that it does that is bacteria produce acid, and that acid will locally open capillary beds and arterioles and produce broad full body vasodilation, which can tank your patient's blood pressure even if they're not actively losing blood. If you combine that with a raging fever, bad news bears. So I want to stress vasodilators, while local autoregulation, they are important. In certain medical situations, they can be at a disadvantage to the health and well-being of your patients. All right, neural mechanisms. We have the cardioacceleratory center and cardioinhibitory center in the medulla oblongata. And remember, those are going to innervate, if you think about the medulla oblongata and the branches of the nervous system. Craniosacral division of the nervous system is parasympathetic, and the cardioacceleratory center is actually linked up to the cardiac nerve, which is a sympathetic one. So heart receives both. And then, of course, we also have the vasomotor center, which causes the vasomotion of the arteries. So the input, the afferents here, comes from both the higher brain, but also proprio-baro and chemoreceptors. So for example, if I'm laying down and I'm going to sit up quickly, I'm going to expose my vasculature in my heart to some major changes in pressure from changing my body position. So proprioreceptors tell my brain that my body position is changing, and that's going to act on my cardioacceleratory center to increase my cardiac output enough to overcome the pressure changes that I'm putting my body through. So, vasomotor center causes the following. And remember, this is going to go back to the autonomic nervous system chapter. So if you're rusty on autonomic nervous system, it's worth brushing up on, because a lot of the stuff that we've discussed so far this term is actually controlled by both. So giving yourself a bit of a refresher on, what kinds of neurotransmitter are released by each division and what kinds of receptors exist and what their actions tend to be is not a bad idea in preparation for the final exam, but also in preparation for demonstrating full understanding of what we're learning now, because showing that you understand regulation of these new topics is just as important as showing that you understand sort of the basics of them. So, what does the vasomotor center do? Mostly it constricts, and this is via adrenergic action. So we've got norepinephrine, for the most part, causing vasoconstriction, so moving blood away from the periphery, and that allows blood to be shunted towards things that need blood in a fight or flight situation, so skeletal muscles in the brain, for example. And so vasodilation here is cholinergic and nitroxidergic. So one thing to remember is that although we commonly think of the sympathetic postganglionic fibers as being adrenergic only, there are a small number of them that release acetylcholine or that release nitric oxide. So we're coming back to that topic here. Vasomotor tone is under sympathetic control as well, and this is just basically, since the vasculature and the vasomotor stuff is regulated only by sympathetic nervous system, it's not a push-pull between parasympathetic and sympathetic, but rather the more action potentials per unit time the control center is sending, the higher the amount of control will be. So the increased or decreased activity of the center influences resistance via blood vessel diameter really, really strongly. So it's a very, very potent changer of resistance and therefore flow. So to drive this point home, we've got this number here, and that is, if you look at the outside numbers, the resistance difference between a maximally constricted and a maximally dilated arteriole, so the ones that are the gateway to the capillary bed, 80-fold. So 80 times as much or as little flow. So that's a really big number, and it really strongly influences capillary perfusion as well. Okay, so I mentioned that change in position thing. There's also change in respiration. So when we get to the respiratory system pretty soon here, we'll talk about how the heart keeps up with the lungs and how the lungs modulate their action according to the heart. So your heart and your lungs are kind of always talking to each other about what needs to happen so that their actions match. One of the ways that works is the carotid sinus, which is in the external carotid artery, or excuse me, the internal, my bad. And this basically contains a group of cells called glomus cells. That's Glomus. And glomus cells sense dissolved oxygen in the carotid. So what they're doing is detecting how much blood indirectly is reaching the brain. Okay, baroreceptors. These are stretch receptors. So they're going to detect, by detecting stretch, the hydrostatic pressure in your blood vessels. So if you think about a stretchy walled vessel, like an artery, if there's more blood in there, the walls of the vessel are going to be more stretched, and baroreceptors detect that and send that information to the brain. So there's baroreceptors in both the carotid sinus and the aortic sinus. And then cardiovascular centers like the cardioinhibitory and cardioacceleratory center integrate that information and then make the appropriate change, basically. So you can see that there's two interlocking feedback loops. Both of them have a short leg and a long leg, and both of them are capable of dealing with either rising blood pressure or falling blood pressure. So basically the idea with this top one is that if you get rising blood pressure, you want to do a couple things. One is reduce resistance by vasodilating. The other one is decrease cardiac output, and hopefully that brings blood pressure back down to normal. And then basically the opposite set of things occurs if you get falling blood pressure. So for chemoreceptors, I mentioned those oxygen sensors. So you have aortic and carotid bodies as well. You also have sensors on the ventral surface of the medulla oblongata. So your book is a little bit general about these. The carotid and aortic bodies, those are the oxygen sensing ones. The sensors on the ventral surface of the medulla don't actually directly sense oxygen, they detect pH. And that's because the amount of dissolved carbon dioxide in your plasma, a lot of that gets converted over to acid. So pH is an indirect way to measure CO2, and that's an indirect way to measure gas exchange. So when we get to the respiratory system, that will make more sense, but suffice it to say for now that the carbonic anhydrase reaction that you learned way, way, way back in 160, where water and carbon dioxide form carbonic acid and then bicarbonate, for example, that matters a lot, both for this system that we're talking about right now and for the respiratory system and its regulation as well. So basically, same deal. You get changes in chemicals, either in dissolved gases or in concentration of hydrogen cations, and then cardiovascular centers take that information and decide what to do with it. So they're going to change cardiac output, change vessel diameter, and also change the rate at which you're respiring to bring those levels back within normal range. So I'll let you explore this feedback loop on your own time. I don't feel it necessary to read it to you because it's pretty self-explanatory. You guys are smart enough to do that by yourself. Okay, so we've discussed the hormonal influence already. These we pretty much did in service of talking about the endocrine system. So we talked about the renin-angiotensin-aldosterone system already. We also talked a little bit about antidiuretic hormone and atrial natriuretic peptide. So these two are going to oppose each other. So I would recommend going ahead and reading the recap of these two things. So Cliff's Notes version, antidiuretic hormone causes you to reduce the amount of urine that you're producing and keep that water in your blood. Atrial natriuretic peptide does the opposite. So it causes an increase in water release from the kidneys. Angiotensin is going to be related to that angiotensin system, a really potent vasodilator. And then erythropoietin is also involved, and that's going to cause an increase in red blood cell production. Okay, so again, we have a bunch of figures here, and I don't think it's a great use of our time together to read these because you guys are capable of reading these yourselves. And then if you have questions about parts of the feedback loop, that would be good to ask me in subsequent Zoom sessions. But you know, it's not, I don't need to read you that renin release leads to angiotensin II activation. That's insulting to your intelligence. I know that you guys can do that. So not going to read you these feedback loops, but I do want to point out that they are important to understand. So go have a look at them and then come back and ask me questions about them. And I think you'll find that, like, here we have the autonomic nervous system being mentioned, and here we have cardiac output being mentioned. So your takeaway from these should be basically integrating stuff that you've learned previously with stuff that you're learning now. And it should be all kind of coalescing into a bigger picture at this point. Okay, so shock. What does it mean? We've all heard about people, quote unquote, going into shock, but a lot of times that's not really physiologically characterized at all. It's just you see a person staring vacantly into the distance, wrapped in a blanket, sitting on the back of an ambulance, or what have you. So shock is actually really dangerous, and watching for signs of shock as a clinician is one of the ways that you can help save your patient's life. So it has lots of effects. Basically, shock is inadequate cardiac output. So something is preventing your heart from doing the work that it needs to do, which is preventing your heart from putting out blood. And that's going to prevent flow at your capillary bed, leading to stagnation and tissue death. Not great. So it can result in dysfunctional cell membranes. It can and does result in abnormal cellular metabolism. And if it's prolonged enough, can ultimately lead to cell death. So the most widespread kind of shock is hypovolemic, which I mentioned previously, so low blood pressure shock, because again, low blood pressure means that your capillary exchange is impaired, but it also tends to impair venous return, and your heart can only pump out what it receives. So you get into this shock-based positive feedback loop that is very dangerous and hard to come back from, which is why shock has stages. So you can get hypovolemic shock from hemorrhage, and this is obviously related to excessive fluid loss. So chronic diarrhea is one. So you see hypovolemic shock in cholera patients. Sweating. Obviously, you know, you sweat to cool yourself, but there's a limit. Vomiting is another one. Dehydration in general, and also burns. So burn victims are really, really vulnerable to hypovolemic shock due to dehydration because they lose so much water across the skin surface that is burned. So if you work in a burn unit, that's something you learn very quickly, is that management of fluids in burn victims is a critical component of keeping them alive. Oh, one thing I want to note before we move on is the stages of shock merge with each other. So it's not like you could stand by somebody in shock and be like, ah, they've entered stage 2. It's a continuum. So compensated shock is when the body is still able to take measures to oppose the shock that's occurring. So this is your body batting down the hatches and being like, all right, shock is happening, we're ready to go. So we're going to activate the renin-angiotensin-aldosterone system. We're going to use the vasomotor center to increase resistance. We're going to use ADH. It's basically throwing everything it can possibly throw at the problem to oppose low cardiac output. This is possible if the blood volume loss is less than 20%. Decompensated shock occurs as the blood volume loss approaches 30%. And I mentioned that you get into this positive feedback cycle, which is really hard to break out of without severe medical intervention. This is what I'm talking about. So if your cardiac activity decreases due to not receiving enough blood, because remember the coronary circulation is included, you get ischemic myocardium. And ischemic myocardium, low oxygen myocardium, isn't as able to contract. So it reinforces this depression of cardiac activity. Bad. If you get this depression of vasoconstriction, the medulla oblongata becomes ischemic, so you can't get blood up to your control center, and it starts to malfunction. So it becomes incapable of controlling the stuff it's supposed to control. Increases in capillary permeability decrease blood volume as well. And as you get this increase in capillary permeability, fibrinogen starts to precipitate out of the increasingly low blood amount. So your blood loses water and increases in osmolarity, and then you get this intravascular clotting, and that reduces cardiac output more. Acidosis as well depresses the medulla further, and then you start to get just body-wide cell death due to ischemia. So obviously this is very bad, and this requires intervention by medical people. Hypovolemic shock stage 3 is irreversible. So this is when your body is basically shutting down. So there's nothing to do about this, cannot be reversed by the body or medical intervention. Basically, stage 3 is what you want to avoid, because stage 3 is when the patient is so far into their positive feedback loop that you don't get to pump anymore, you don't get any more ATP produced, you don't get oxygen exchange, and death is not far away. Okay, so I'm going to ask you guys to read the fetal circulation component for yourselves, and then ask me questions if you have questions about it. It's pretty straightforward. It's just ways for the fetal circulation to bypass the lungs so that they can grow but not, you know, be subject to the powers that would exchange oxygen, because of course fetus gets oxygen and nutrients from the placenta, not its lungs. The podcast before last has a lot of details about this fetal circulation. So if you want a talk through of it while you look at these slides, I would go through that one, because it describes not only the development of fetal circulation structures, but also how they close up at birth. And then if you have questions about that, go ahead and ask me in Zoom. So for now, I'm going to stop recording, maybe.